time surgery is undertaken, the clinician should have a fairly good understanding of the anatomy of the area that the clinician is entering. And in many instances, although there are some clinical tasks that you can do very simply to learn about the anatomy, much of the information is often gained through imaging. So there are a number of anatomical considerations of the jaws and in the maxilla. These include the position of the floor of the nasal fossa, which constrains the vertical height of bone available. But often a lot of people don't understand that there's an incisive fossa there as well as an incisive canal, and these may constrain the buccal-palatal dimension of the bone. In the posterior maxilla, certainly the floor of the maxillary sinus is an important consideration, and sometimes septation within the sinuses may prevent you from doing a bone graft or a sinus lift type of procedure. In the anterior mandible, it's a pretty safe area. There is, of course, the mandibular canal and the lingual foramen there, and there are certain studies that have been published that have demonstrated some adverse effects with respect to bleeding if that lingual foramen has been punctured. The other issue in the anterior mandible is that long-standing edentulosum, as many of you know, can cause a substantial thinning of the buccolingual dimension of the bone, producing an almost knife-edge type ridge. In the posterior mandible, the mandibular canal and the mandibular foramen will also constrain bone height, but more importantly, in the posterior mandible, the submandibular salivary gland fossa may constrain the buccolingual dimension. Now, many different imaging modalities have been used over the years, including projection radiography, advanced imaging, 3D imaging. And in fact, panoramic radiography amongst all of these different modalities has probably been used the most extensively. There are also a lot of papers in the literature that tell you that there is a high degree of predictability and efficacy of panoramic radiography in predicting the amount of vertical bone available. And that's true, because in panoramic radiography, the vertical dimension is actually a much more reliable dimension to measure than the horizontal one. But nowadays, projection radiography and panoramic radiography really have little direct use in dental implant treatment planning, except maybe at the outset to rule out any abnormalities in the intended site of implant placement. So this is a panoramic radiograph of an individual who was being treatment planned for dental implants. And I think very nicely you can see in the little red circle that there is a mixed radiolucent radiopaque entity in the area of the proposed implant site. But if you step back a bit and you look at the entire panoramic image, you can see many other similarly appearing entities all through the maxilla and mandible. And these represent sites of florid osseous dysplasia. It's well known that in the most mature form of this disease, of this dysplasia, that the vascular supply in these areas is actually very, very limited and restricted. And this can have a negative impact on the patient if a dental implant is placed here. So nowadays, what we typically do when we see patients being treatment planned for dental implants is we protocol cone beam CT or medical CT scans. Since about the early 2000s, I think cone beam CT has really very nicely incorporated its way into the profession. The earliest of these machines is similar to one of the ones that I've shown here, which are large field craniofacial machines which have fields of view size of upwards of 12 inches in diameter, able to capture an entire human head. These have been made by a number of different companies, and these are some of the examples. The smallest of these systems may have a 6-inch diameter sphere, whereas the largest ones of these systems may incorporate a 20-centimeter diameter field by 18 or 22 centimeters in height. These are very, very large fields, and they can encompass, as I've said, the entire human head. 17 centimeters is pretty big. This is an example of a craniofacial study through a patient's head. You can see that it captures the entire edentulous maxilla, as well as both mandibular rami, and then posteriorly to the cervical spine. So it's a very, very large area. More recently, about 4 or 5 years ago, companies began introducing systems that could offer the acquisition of a more limited field of view, somewhere in the 8 centimeter diameter or less. This is one such system. And many of the smaller systems are coupled with panoramic systems. So it's simply a matter of buying the second image detector to attach to your panoramic system, and you can do both types of imaging. Many of these systems do have small fields of view, and they range from as small as 4 centimeters in diameter to 4 centimeters tall, up to about an 8 centimeter diameter field. And as I said, many of these systems are quickly being introduced in the market, and many of you may actually already have such systems. A lot of people have said to me, you know, 8 inches is really small, it's too small. But here's 8 inches compared to 17 centimeters, or 8 centimeters compared to 17 centimeters. An 8 centimeter field will allow you to capture, you know, most of the maxilla and most of the tooth-bearing areas of the mandible. A smaller 5 centimeter field may allow you to capture a sextant of the jaw, and depending on the size of the jaws, you may actually be able to capture a good deal of the information that you would like to capture. So just as an example, this is a very small field of view. This is a 5 centimeter diameter field of view. On the left-hand side, this is the axial cut through the anterior maxilla. You can see in this individual, we've been able to easily capture from the first or second premolar to the first premolar on the opposite side. That's quite a lot of space. In the posterior mandible on the right, you can see we've captured about 5 spaces between the canine and the second molar. Now, one of the really brilliant things about these small field machines is that the voxels that are used to capture the images are exquisitely small. So many of the voxel sizes range from as small as 76 microns to as much as maybe 400 microns. But the majority are sort of clustered around the 100 micron voxel size. The 100 micron voxel size or less images produce exquisite images of bone. On the right-hand side, this is a patient who was scanned with a 76 micron voxel size. And you can see very, very nicely the clarity of the trabecular bone in the mandible. It's really beautiful. On the left-hand side, this is another patient who was scanned with another machine at 300 microns. So the voxel size was 4 times as big. And you can see that there is some loss of trabecular detail. Now the question is, does the 300 micron voxel size produce less diagnostic images than the 76 micron voxel size? Well, unfortunately, we don't know quite yet. But many studies are underway to try and bring out answers to those questions.
When I ask a question in regards to now the differentiation of getting enough information from this, and as we've discussed before, there are certainly questions from the patient, okay, what is the radiation exposure? It's in certain media, it's certainly a big topic to make patients aware. So how can we answer to this? Should we always go for a small field of view, or does it matter in regards to the resolution we need? So how does this correlate now? And what is my best option that I have today?
Sure, so radiation concerns have always been a concern of patients, and I think more and more as the media begins to pick out papers that are published in our literature, a lot of this information is almost sensationalized in the media. But you know, if you're prescribing imaging, you need to understand the risks. And the risks typically involve damage to DNA in cells. And in particular, to things called double-stranded breaks, where there are lesions that are induced in both strands of DNA. If DNA is repaired, and it can be repaired, if it's misrepaired, it can lead to mutation. And mutation is well known to cause changes in chromosomes that have been linked to the development of cancer, not only in cells in culture, but in animals and in humans. Many of us, when we talk about radiation, or when you hear about it in the press and in hallway conversations, people like to talk about exposure. But exposure is actually an incorrect term to use, and you really shouldn't be using that term. Because exposure really is an in vitro type of measurement where you measure the amount of ionization that occurs when an X-ray beam or any ionizing radiation source travels through air. What we actually are more interested in are numbers that reflect the absorbed dose, which is now measured in gray, or the absorbed dose equivalent, which we measure in sievert. For X-rays and gamma, or for X-rays, the absorbed dose and the absorbed dose equivalent are really essentially the same thing. So you can sometimes use those units interchangeably. We know that after many, many years, scientists have said that radiation risks are more substantial now than ever. Many of these studies have been longitudinal studies followed in patient populations or subject populations who have been irradiated over the course of many years. Now, when we look at radiation in the background annually, we all receive between 3 or 4 millisieverts of radiation per year. And there's some variation depending on where you live on the Earth, but this is a good number to sort of keep at the back of your mind. For the large field systems, you can see that the dose is it's very wide, it's very broad. For a 12-inch field of view, it can range from 68 microsieverts to over 1,000, which is actually more than a medical CT study. Why is there so much variation? Well, these different machines all have different image receptors. They all operate at different kbps and MAs. Some of these machines emit radiation in a continuous stream, where others will emit radiation as a pulse. So obviously, for pulse radiation, or pulse machines, the radiation dose is less. This is a nice little graphic that demonstrates on the y-axis dose equivalent, and on the x-axis a number of different technical factors that were modified. The red arrows show different fields of view size, with all other factors being equal. You can see when a 12-inch field of view is used, and that's the red arrow at the far left, the dose is about 600 or 700 microsieverts. But if you choose a 9-inch field, that dose drops to just about 400. And if you go down to a 6-inch field, the dose drops to 145 microsieverts. So field of view size makes a big difference in the amount of radiation your patient receives. For the small field of view machines, there's not a lot of data out there, but this is one study that was published by one of my colleagues, John Ludlow, at the University of North Carolina, for one particular small field machine that demonstrates a variation of between about 5 and 38 microsieverts for a small field of view cone beam system. You'll notice that there is a variation depending on where you're located in the arch, because different areas contain different radiation-sensitive tissues. So in areas like the anterior maxilla, where there's not very much radiosensitive tissue, the calculated dose is lower. But in areas like the posterior mandible, where you may capture part of the submandibular salivary gland, which is one of the more highly radiation-sensitive tissues, the calculated dose is higher.
Very good, but as you said, we have so many parameters now that we can change the field of view, we can change obviously the radiated dose that we expose the patients to. What's the room for improvement? I mean, how do we continue with this? Will this be complicated? So do we need to decide for each and every patient of what's the field of view, and what radiation is the ideal for a certain treatment, or will the software or the systems help us in the future?
Sure. So when you have a patient who you'd like to do some imaging on, one of the things that you have to consider for yourself or for the patient is how many implants do you think you want to place and where do you want to place them. And we typically will choose the smallest field of view size, and we'll choose a KVP and an MA that produces images that are of a high enough quality that overcomes electronic noise so that the images are most diagnostic. One of the things that people have tried to do for a long time now is trying to quantify bone density from cone beam CT scans. And unfortunately, in spite of the fact that a lot of people are doing this, the numbers are actually very unreliable. In the day when medical CT was first invented, a fellow named Hounsfield was the fellow who was on the ground floor who invented these systems in England. The density measurement for different tissues in the body has a number that is associated with it, and that's named after this fellow Hounsfield. And these are called Hounsfield units. The Hounsfield unit really represents how different tissues absorb radiation. And you can calculate it out mathematically quite easily. Now, with respect to bone, there is a window of Hounsfield numbers that is associated with bone. And in fact, on a medical CT scan, you can place your cursor on a tissue and you can ask the computer, what's the Hounsfield number of this particular tissue, whether it's cortical bone, cancellous bone, salivary gland, whatever. And the computer will tell you what that number is. Unfortunately, in cone beam CT, it is not possible to do this because the intensity of the image is actually quite variable and it's arbitrary. So at present, we know that different tissues attenuate radiation differently in cone beam CT scans. And these numbers actually vary depending on the machine that you choose to use and the technical variables that you choose when you do the acquisition. So at this time, we cannot reliably determine Hounsfield units from cone beam CT scans, and as a result, we cannot reliably determine bone density. So just to give you an example, this is a craniofacial cone beam scan, and what I've done is I've placed my little region of interest in 3 different areas of cortical bone. One on the lingual surface of the mandible, one in the skull base, and one in the inferior border of the mandible in the anterior part of the jaws. I've asked the computer to calculate a Hounsfield unit, and you can see that the Hounsfield unit here varies between 731 and over 3,000. And this is the same patient, it's the same cortical bone. So it's not particularly reliable. The other interesting development which may come down the line relates to the ability of these systems to depict soft tissue. Unfortunately, right now, cone beam systems are incapable of reliably showing soft tissue. And in my opinion, that is a major downfall of these types of imaging systems. Unlike medical CT, cone beam CT still can't do this. So just as a demonstration of why that might be interesting. On the left-hand side, this is a medical CT study. On the left-hand side, this is the bone window view demonstrating a tumor in the right posterior mandible. This is just a classic ameloblastoma. And on the right-hand side, this is the same patient where we've asked the computer to show us the soft tissues. And you can see very nicely how the soft tissue tumor extends out into the adjacent fat underlying the skin. So you get a lot more information about the interaction of soft tissues with adjacent soft tissues in medical CT, and perhaps in the future we will be able to incorporate this type of technology into newer cone beam systems. Certainly, most of this is really in the hands of computer engineers, and the development of novel reconstruction algorithms and in fact better detector systems for our CT systems may lead to better imaging systems that will allow us to solve both of these problems. Thank you very much.